We need to figure out how to be there when a patient wants, what they want, where they want it, when they want it, how they want it. And I would argue we even want to be there before they even know they want it or need it. And what that looks like is, in a hyper-personalized experience, how can we tell you that you are going to be a diabetic 5 years before you declare yourself as an overt diabetic?
Hello, healthcare. I am excited to be joined by Dr. Daniel Derman, who is the Chief Innovation Executive at Northwestern Medicine. Daniel is a practicing physician in internal medicine, and when we use the term innovation, obviously means so many things to so many different people. There's all kinds of different paths that we can go. But what I wanted to talk with Daniel about, and you've been in that role for 27 or?
Actually, in a month, it'll be 38 years at one place at Northwestern Memorial. I've had a number of different responsibilities besides running a primary care office. For the last 6 years, I've been the Chief Innovation Executive.
Excellent. So what excites me about that, especially like the last 6 years that you mentioned, is that in healthcare, there's a mixture of risk aversion, which I think is very valid in a lot of cases, extremely regulated industry. But there's the huge question of, when we start looking at innovation, where do we go? What's our guiding star? What guides the path that we take? And Dr. Daniel and I have been having some good conversation on what it means to focus on the patient, how to personalize our offerings, and basically where that's going with the overall patient experience. So with that, Daniel, you're the best to introduce yourself. Just wanted to get your perspective on your background and what's brought you down this path of focusing on innovation so totally.
Got it. And I'm going to come back to the innovation, and you brought up a really important point, but you want a little bit about my background in terms of I'm a practicing internist, been at Northwestern my whole career. I didn't have any particular expertise in innovation when they tapped me to do this. My CEO knew that we were doing everything we could with the way healthcare systems were built and the ecosystem was operating, but we didn't have anyone who was out there thinking about how the world's going to change and how we can prepare to do that. And in my prior life at the hospital system, I introduced a lot of new innovative ideas, but the real reason they tapped me was that I really understood operations. And one of the challenges with innovation is, in many places, innovation is out there on an island, not connected to the main part of the hospital system. So they're out there finding answers without actually answering or asking the question. I get an answer, and now I go find someone who's going to ask the question, if that makes sense. Mm-hmm. So I find this new, cool technology, and then I go looking, is there anyone at Northwestern that wants to use it? Well, that's bass-ackwards, as they say. And I learned, and have a lot of scars in my back through time, that the really right way to do this is embed yourself with the operators to find out what their problems are, and then go try to find solutions, be it companies or new ideas generated by our own faculty and staff, to try to answer those most pressing needs. Anytime I came up and found a new technology and then went to find a sponsor or a champion, they almost always didn't take hold. So I would say that's one of the principal lessons, is let innovation start with the operators. And any project we do now always has an operator attached to our hip. Now, one other thing you brought out in the introduction, which was really wise, and I don't know if you realized it, but innovation, the way that medicine is designed is we use something that's called evidence-based medicine. Theoretically, a drug does not touch the body until we've proven that it's safe and that there's a benefit to it. That's what we call evidence-based. We don't do something to any human being until we've proven it that it's safe. Well, now let's think about innovation. Innovation means taking a risk. It means doing something that isn't proven. You couldn't get two cultures that are less designed to coexist then evidence-based medicine and innovation. And not only is it our clinicians that are evidence-based, but that ethos has worked its way into the administrative group as well. We just don't do things in healthcare unless we have an idea that it's going to work, and a really good idea that it's going to work. So the idea of trying new things does not really sit well. And for us, so with that being the issue, I go back to the way that we solve that is by bringing the operators in early so that we can try something. And one of the watchwords or the phrases in innovation is fail fast. Try something. If it doesn't work, modify it again. And if it doesn't work, move on to something else.
A lot of the points that you bring up too, they really resonate with me because I'm gonna call myself guilty, or I'll call it like the healthcare tech industry guilty on one aspect of, here's the problem: we make things sound cool. If we say that artificial intelligence is like the solution to all these, is extremely awesome, extremely powerful technology, then doggone it, like people will start looking for, well, I want to use natural language processing, or I want to use these technologies. But the point that you're bringing up so powerfully is, for what? If we're starting with just how great that technology sounds, those shiny objects, then it's kind of that solution. Well, hey, we bought this thing, and now that's our hammer, and everything starts looking like a nail.
That's right.
But by starting from the operator's perspective, by understanding, hey, when you say operator, are you referring to who are you referring to exactly when you say operator?
So those are the people in the trenches that are actually dealing. So my example is with the healthcare system. It could be a payer. It could be a new tech company, it doesn't matter, but the person who's in the trenches who is really trying to figure out. So let me give you something in context today. I think everybody knows with COVID and the epidemic that labor shortages are a tremendous problem, and particularly in nursing. So our use of contract nurses has gone way up in the last 12 months or longer. So we're looking at and very focused to go out and find a digital solution or a technology solution that would help alleviate the need to use contract nursing, which comes in at a very exorbitant rate. So right now we're piloting a new technology that we developed that is a remote nurse with listening that could listen in and do the documentation. I don't know if people know this, but a typical nurse on a shift will spend anywhere from 48 to 56% of his or her time documenting in the electronic medical record. If we can have a remote nurse listening in, doing some of that documentation, and take half that off their plate, we've now returned 50%, half of that. We've returned 25% productivity to the healthcare system. They could do with it what they want. They may say, nurse, we're now going to give you 25% more time at the bedside. They may cut the FTE count of who they have to have in a shift by 25%. We don't actually care how they do it. Let them make the best decision for them, but we've given them the tools to do that. So that's an example. And by the way, now getting what you're talking about, AI, down the road, we start with remote nurses who are listening in, but eventually we're going to use AI and listening to document that all without the need for a human being. So, you don't get me going about AI, but if you did, I would say one has to be very, very careful. It's kind of corny to say this, but it's really augmented intelligence rather than artificial intelligence, and it gives the person that's involved with it the ability to operate at a higher level of their degree. So my example with the remote nurse or the AI use with that is now we don't take half of a shift for a nurse to just document, I gave the patient sub-Q heparin, but something else or someone else does that. So the nurse can do only what the nurse could do, and that's discharge instructions. Do you understand, Mrs. Jones, that when you go home, you have to do this with your bandage or that with your bandage? That's a really good use of the nursing skill rather than documenting I gave sub-Q heparin.
And I got to say, reading into the subtext of what you're saying, and the focus on operational results, the focus on like staffing capacity when addressing these technologies. If you're reading the subtext, then you're getting a really good education in how to approach these innovation and business in general. So one question that I wanted to get into, since we all of a sudden got into a conversation on personalization, like I'd like to just like kind of riff on this personalization concept, and first start off with like your perspective on when you're referring to personalization, because it's something that a lot of people seek. It's a lot of different there's a lot of different answers to that question. What's the perspective that you have on personalization?
So let me start very big picture, and I'll kind of show my age, because the examples I'm going to give, you could probably come up with much better examples than me. But let's put a team photo picture up. And let's have Amazon in the picture, Grubhub, HelloFresh, Airbnb, and a healthcare system. What entity that I just described doesn't fit in that team photo? Healthcare. We don't do anything. And again, there's better examples than the ones I gave. I'm showing my age as a 63-year-old male. There's probably better examples. But the fact is, all of those companies do a much better job of understanding who you are than we do in healthcare. Now, granted, I can get up on my high healthcare horse and tell you, but we're so much more complicated than all these other ones. They have it easy when you're just trying to figure out, where do you want to rent a place or where are you going to be picked up? They have a much easier job. But the fact is they do a great job and we do a terrible job of it. So let me start by saying that we need to figure out how to be there when a patient wants, what they want, where they want it, when they want it, how they want it. And I would argue we even want to be there before they even know they want it or need it. And what that looks like is, in a hyper-personalized experience, how can we tell you that you are going to be a diabetic 5 years before you declare yourself as an overt diabetic? And what might we know about you that says you're at high risk, and you know what? You may have colon cancer before you ever go and get a colonoscopy that proves that you have colon cancer, because I've noticed, or I can track, that your blood count has slowly been drifting down, that we use AI to determine that rather than the skill set of an individual provider who has to look at that and go, hey, it's gone down by a little bit, because most people blow that off. So I think understanding and providing all that experience for a patient, it's what I call a patient CRM. Nobody has that. People do different parts of that really well. I'm sure there are healthcare systems out there that have a beautiful kiosk system right now, so that when you go in, they don't have to give you that old clipboard where you fill in your name and your allergies and the medicines you're on. There are people that do a really great job of that today. Some do, some don't. But that's at the bottom of the pyramid. We got to do all that really well. We have to know what your preferences are. Do we want to contact you by email, by text, by phone? Those are all simple stuff. What language you use. You've been an inpatient, so we know that you're a pescatarian, not to give you meat. That's table stakes. As you go up the ladder, we know more and more about you and help your navigation be personalized for you. At the top of the pyramid today are all the omics, genomics, and it's what do we know about you and your DNA, and that's going to say what's going to happen to you in the future. Right now, that's the top of the pyramid, so to speak, about what we might know about you. But chances are there's something else that's going to replace that. So as I said, there are different people that do a good job of bits and pieces of this, but nobody has put that all together in what I call a clinical CRM. And for us as incumbents, i.e. those that now take care of a lot of patients, if we want to maintain that position, we're going to need to figure that out, because a lot of people, disruptors, are nipping at our heels that are doing a better job at it than we are in components of it. My challenge is to figure out how to do across the board a great job of that across the lifetime of a patient. So how do we do a great job of that with wellness, with a chronic disease like diabetes or rheumatoid arthritis, a time when you have an acute serious illness like we found breast cancer or colon cancer or you had a stroke, how do we do a good job across all that continuum? That's really, to me, the holy grail of a hyper-personalized experience.
Well, I love that description, and I think that one thing that we can zoom in on is you say that some folks are doing it well in pieces and parts. Could you describe like what like when you say pieces and parts? Is that by category of illness, or is it by some other operation? Like what would you say is that kind of the pieces and parts that are coming
Right.
starting to show
So
some
I
promise?
described some of those already. For instance, this idea of a kiosk so that we know who you are and you don't have to repeat. It's maddening to everybody that everywhere you go, you got to pull out your insurance card again. You got to show your driver's license. That's very simple stuff. But there are many healthcare systems that are also doing these patient journeys. They're mapping out, for instance, in the world of a heart attack, they're mapping out the whole journey of a patient and they're knocking down barriers so that a patient and their family can have an expedited, great experience if it's a cancer, God forbid, or a heart attack. I'm not critical. Those are perfect examples of doing a great job, and we have to be doing those activities. But in a lot of places, those are in a vacuum. They're responding to specific patient journeys for a particular illness or set of challenges that a patient has. I'm looking to think about how we might do that more globally and fit those in under a general rubric of putting together a hyper-personalized experience.
So, do you see that as potentially one approach that is able to be generalized, or do you see it as a collection of different approaches and responses to different?
Yeah, honestly, I'm sorting that through right now. That's exactly the work that my team and I are doing. I think one way could be just doing these individual ones and then figuring out how to string them together. I'm worried, knowing how healthcare works a lot of times, that it's so idiosyncratic that once you build one for cardiology, congratulations, you have it for cardiology. And the Venn diagram between how you built it for cardiology and how you build it for cancer is going to have an overlap of 20-30% instead of an overlap of 80-90%. So that's just some early thoughts. I'm not sure, and the jury's out on it. I know a lot of places that are building these journeys, and we may do something similar like that. But that's the challenge I'm having now, is trying to figure that out.
Yeah, and perhaps like there's like an overlap in pathways that doesn't match up entirely. But if there's the same underlying structure behind that, so let's say that like your cardiology your cardiology path involves outreach at these specific times and like bringing for these specific conditions and things like that. It strikes me that these idiosyncrasies, like the reason why it is so fragmented, is because the reality that there's so many different systems.
So here's an example, for instance, like take cardiology, oncology, cancer, or a stroke. In all of those, nutrition plays a very important role. Probably, by the way, parenthetically, the providers don't give it enough homage of how important it is, but we'll leave that aside. But those are the things that you can build the unit or the bolt-on of how nutrition fits in, where it may vary a little bit. Cancer may be 4 degrees off of it, but probably 80-90% of the essence of it is the same platform. And then you just do some tweaking to fit what are the needs of a stroke versus cardiology versus oncology, as an example.
Yeah, and like when we bring it back to that patient CRM perspective, it just seems like the foundation that we would need is something that is like you have a general foundation that can do all these sorts of things, but it has to be really flexible to these.
And that is the idea of a platform. Listen, everyone talks about a platform. The ideal platform is something exactly that. It's a platform for which you stand on or you build off of that gives you anywhere from probably 60 to 80% of what you need, and you tweak the rest. But that's a lot different than a point solution where you build it and it specifically applies only for cardiology at Northwestern. That's really not helpful for other disease states or if you go outside of Northwestern.
Indeed. So the way that you describe this, like I want people to have something tangible as a way, like we know that hyper-personalization to the degree that we're discussing, that's a ways off, and who knows if it's going to be a platform that enables this versus a network of different approaches, best of breed. I'm leaning towards platform that enables that, but that's the subject of another conversation. For this conversation, I wanted people to be able to have a good sense on, like, let's take one of these pockets of personalization that we discuss. How about we dissect that, break that down into what's a good approach to pursuing that innovation versus the types of things that we should avoid in this case.
So this will continue with the theme that I think I hit was understanding who the customers are for your innovation. And I spoke already a lot about this hyper-personalized experience, and you'll notice that I was very focused on the customer, the consumer, the patient. But I will tell you that if you build a module and a platform that has as your target only the customer and the patient, it's going to fail because it's not going to work for the provider side, who is inevitably part of the equation. So it's a dual challenge of, and I'd say that's probably what I'd end with, is the idea of always thinking about who your target audience are and who you need to satisfy. Because if you have two key customers and you only satisfy one of them, it ain't gonna work. So I have built a system that is beautiful for the client, the patient, but doesn't address the needs and doesn't work for the provider. It ain't gonna work. The whole thing will fall apart, even though it's beautifully designed for the patient. So as an example, I guess I'd leave people with this idea of, KYC, know your customer, but really understand who your customer is and who could sabotage or prevent success, and making sure that you bring them in that journey early. Because the other factor is, once I get really wedded to something, and then I bring an operator who has an observation, I'm less willing to take that into account or modify what I do, because I've now built a world that I'm very invested in. Mm-hmm. That's another reason why bringing those people in early before you become invested is a real measure for success.
So know your customer and know your operator, it sounds
That's right. Well, in this case, know your customer is bifurcated, mm-hmm. in understanding that you have, in this hyper-personalized, you really have two sets of customers.
Excellent. Yeah, excellent way to phrase it. And gosh, I think this is like the tip of the iceberg of a really awesome conversation. I bet a lot of people watching, listening, will think that too. So for the people that want to continue the conversation or hear from you, is there a way that they can get in touch or follow some of the things that you're doing?
Well, I don't do podcasts, but do you have the ability to make my email available to folks?
Yeah, we can pop that on the screen.
If you put that on the screen, I'm happy to respond.
Okay. Well, again, thank you very much for joining in with us. Really loved the conversation, and hoping to have more soon.
Great. Thank you very much. I enjoyed it too.
Thank you. And for the folks that enjoyed this conversation, a lot of what Dr. Derman was talking about, especially like the need and the concept for a new platform that can be hyper-personalized, it reminds me of a conversation we had last year with Dr. John Glasser, who was CEO of Siemens, and I believe is an innovation fellow for one of the for Harvard Medical School. But either way, that conversation is available on the screen and in the show notes. It was called "It's Time for a New Type of EHR." So it really gets down into a vision on what we should be pursuing. Thank you for spending a little bit of time with me and Dr. Daniel Derman. And until we see you next time, hello.
If you want more of the latest from healthcare's thought leaders, subscribe using the button below. Or you can visit hellohealthcare.com to get updates directly in your email.